At least 84 countries are reporting a new wave of COVID-19 cases. We'll discuss what's behind the summer surge. Hello, I'm Arnold Ryder, and this is The Heat. The World Health Organization says COVID-19 is still very much with us and is urging governments to strengthen their vaccination campaigns. Officials warn that cases are rising globally with a high percentage of positive tests across Europe and the United States. In Paris, at least 40 athletes competing at the Summer Olympics tested positive for COVID-19 or other respiratory illnesses. The WHO says the rise comes at a time of pandemic fatigue, diminished testing, and low vaccination rates.
I am concerned. We don't sit here and try to speak based on fear. What we work on are scenarios. What our worry is with such low coverage, especially in the at-risk groups, and I'm not saying other groups don't need to be vaccinated, with such low coverage and with such large circulation, if we were to have a variant that would be more severe, then the susceptibility of the at-risk populations to develop severe disease is huge.
Okay, for more on COVID-19, let's bring in our panel. Joining us from Lancaster in the United Kingdom, Munir is a virologist and professor in biomedicine at Lancaster University. Also with us from Virginia, Dr. Kate Telenko is the founder and CEO of Corvus Health. Dr. Peter Chin Hong is a professor of medicine and an infectious disease specialist at the University of California, San Francisco. And from Missouri, Dr. Ziyad Al-Aly is the director of the Clinical Epidemiology Center and Chief of Research and Education Service at Veterans Affairs St. Louis Healthcare System. Thank you, everyone, for being with us. Ziyad, let me start with you. As we just heard, the World Health Organization is concerned about the increase in the number of COVID cases. Right now, it's been found in 84 countries. What is your assessment of where we are right now and the spread of this virus?
We were experiencing a summer wave. This is very, very, very clear in the United States and much of the world, in Europe, in the UK, and elsewhere in the world. In much of the world, there is a significant rise in cases of COVID-19. We know that from wastewater surveillance data. We know that from ER visits. Those are actually increasing. We know that from hospitalization data. People are actually getting, in some cases, not everyone, sick enough to actually be in the hospital for it. So there is clearly a rise in COVID-19 in the summer. That sort of dispels the notion. I really hope that that's is taken as evidence, dispelling the notion that COVID-19 is seasonal. It's certainly not seasonal. We see it year-round, and as a matter of fact, now we're experiencing a significant summer wave in much of the world.
And Ziyad, we are hearing of a more severe variant of the virus that could potentially evade detection. That's because of a lack of testing and also because of low vaccination rates. What do we know about this more severe variant?
So the most predominant variant now in the United States and much of the world, also the KP.3 virus, we're beginning to understand what it is. There is some initial data suggesting that it may be more immune evasive than prior subvariants of Omicron, but those data are actually preliminary at this point. Now, I don't think the jury is out, or I don't think really we have conclusive evidence knowing that it's really more pathogenic or results in more severe illness than the prior subvariant of Omicron. So we still don't know that. However, it is true that it's hitting us at a time where people are totally, masking rates are near zero in much of the United States and much of the world. As a matter of fact, there are some places where they're actually actively banning masking, where vaccination rates have also been very suboptimal or suboptimal at least in the last vaccine that was rolled out in the United States. Vaccination rates for those were very suboptimal. So it's hitting at a time where the population is potentially least protected from if this variant was indeed more severe. But again, I want to reiterate that we still don't know if it's more pathogenic or will lead to more severe illness than the prior subvariants of Omicron.
Mohammed Munir, of course, the world is focused right now on the Paris Olympics, and we're being told by the WHO that there are 40 athletes who have tested positive for the virus at the Paris Olympics. In fact, one of those athletes was one of the main contenders for the 200 meters men's. He was found to have The virus is being treated for that. But the WHO also says that this is not surprising given the rate at which the virus is spreading across Europe. What is the situation in the United Kingdom?
Yeah, absolutely. The overall situation of the COVID in the world is increasing, as Ziyad was mentioning, and the positivity rate has increased in the Europe. That is around 20%, which is quite significant compared to previous months. And when we look at the UK, the situation isn't very different either. I mean, particularly because of the congregation and the riots and the protests ongoing, the overall infection is increasing. I mean, we have had 8% increase in the overall positivity rate. And not only the positivity rate, but also the hospital admission have increased. I mean, we have now 4.25 people out of 100,000 tested positive admitting into the hospital, which is slightly decreased from the last week, but it is still significantly higher. And that is, for instance, if you look onto not just onto the public health perspective in a short term, but in a longer term, even if 1% of those will develop long COVID or conditions similar to those one, it would still be substantial.
Right, Mohammed, there's been one other development in the United Kingdom. A judge who was investigating the UK's preparedness for the COVID-19 pandemic has issued a report. It's a very scathing report. Let's listen to some of what that report says.
I have no hesitation in concluding that the processes, planning and policy of the civil contingency structures across the United Kingdom failed the citizens of all 4 nations.
So, Mohammed, what do you make of that, and has there been any response to that?
Yeah, absolutely. I think one of the major criticisms we've been, discussing within the community is really that since, for instance, last year, not much effort has been put in place by the government in the UK. I mean, one of the major criticism I would like to highlight is abandoning the wastewater surveillance system. I mean, this is one of the most more pragmatic way of looking into what is the infection projection in the near future. It doesn't tell where the infection come from, who is more vulnerable, but it does tell you exactly what is happening, and you have the possibility to look into the sequences and to identify what are the new variant. For instance, in the United States, it's a very good system for the surveillance, but that was abandoned in England 2022 and in Wales in 2023. And without having a wastewater surveillance system, for example, it's very difficult to really assess and project what's going to come. Beside that one, with very little support in for instance, for ventilation, for mask mandating, or even awareness for the masks, particularly into the current situation when gathering and congregations are increasing within the country.
Yeah, we are going to talk about that surveillance system in the United States in just a moment, but I want to get to Kate Telenko right now. Kate, good to see you. Of course, it's summer, and here in the United States, like elsewhere in the Northern Hemisphere, people are traveling for the summer holidays. Here in the US, the travel is expected to break records. 271 million passengers will be boarding flights all over the country. I mean, to what extent would that be a factor in contributing to the spread of the virus?
Well, we know that COVID has been very much like flu and RSV in that it's had a autumn and winter peak, but also we're seeing that it actually has started to have a summer peak, that ever since the summer of 2020, you see a COVID peak during July and August. And that's because as it gets really hot in the US, people spend more time indoors in air conditioning, which increases their risk. They're also traveling more, which increases their risk. So I think we can expect to see this for the future, that we'll have this dual season peak of COVID. And also compared to RSV and influenza, COVID has a higher baseline prevalence, as one of the speakers indicated. So there's more COVID around in general throughout the year than influenza and RSV.
Right, we were talking a moment ago about this more severe variant of the virus. I mean, is it your understanding that the vaccines that we do have right now that are being administered to people is capable of resisting these new infections?
It does provide some protection. Now we know that Pfizer's new vaccine is going to be available most likely by the end of the month, and the other vaccines probably will be available in September. So, for people considering whether to get it now or waiting a couple of weeks, it might be worth it to mask up, wait a couple of weeks, and get the new vaccines. But that's a decision for everybody to make on an individual basis. But there is a concern, as some people have been indicating, that there's this collective amnesia that Americans Americans and others have been forgetting about how bad COVID was. There's also a fatigue as well. And so it is really concerning because you don't see people masking, you don't see people doing proper hand hygiene. So I think as we go back to school in the next couple of weeks, we can expect to see a lot more COVID as well.
Right, okay, let's go to Peter in San Francisco. And Peter, here we are talking about COVID again. Peter, I want to talk about the surveillance system that Mohammed was talking about a moment ago, and that is federal data shows us that coronavirus levels in California's wastewater are surging to levels not seen since 2022. In fact, there was a headline in the Los Angeles Times which said, COVID surging in California nears 2-year summer high. Almost everybody has it. What is the situation in the state?
So what happened in California is two things. First, it came about a month earlier, and it never let go. So we would have thought by now that we would have seen a plateau and a decline, but it continues at full force. And I think part of it is that we saw a changing of the guard within the summer from some of the earlier KPs like KP2 and KP1 to the one that you just mentioned, KP3.1.1. That might be part of it, as well as some of the other factors like heat waves, wildfires in California, bringing people indoors. It's kind of our version of winter.
Right, and are more people getting sick, Peter, because they've not had the vaccine since last fall?
Well, we know that emergency department visits and hospitalizations have gone up, but our baseline was really low a few months ago. So when you put it in perspective, it still doesn't compare to 2022. So in 2022, same amount of virus, probably even more, but a fraction of the people going to the hospital. But you can look at it glass half full or glass half empty. To me, I think all of these hospitalizations, all of these deaths are really avoidable given the tools that we have.
Right, Ziyad, let's talk about this variant, KP 3.1.1. As you've pointed out, it's particularly virulent. The CDC says that it accounts for 28% of infections nationwide. That was in the 2-week period that ended on August 3rd. What can you tell us about, the properties of this virus that make it so virulent?
So it's clearly now becoming, the predominant strain of Omicron that is predominating in the United States, clearly overtaking, all other subvariants. And it's really rising very, very quickly. And it's likely responsible for the surge, and in many, many ways responsible for the surge. So what do we know about it? We know about it, it may be, again, these data are still preliminary, but it may be more immune evasive than prior subvariants. It also may be more infectious than prior subvariants. We still don't know if it's really actually results in more severe disease than prior subvariants. All of these observations are preliminary because remember, this is a new kid on the block. We're still trying to understand what it's doing and all of that. But nevertheless, I think it's sort of as the other speakers pointed out, I think it sort of comes at a time where the population in the United States and actually in other places of the world are least prepared to deal with it because of low vaccination rates and low testing, no masking, et cetera, et cetera. So we let our guard down. We're not vaccinated. We're ill-prepared to deal with a surge, yet a surge is happening. And no wonder in the United States, if you look at the hospitalization data, those are actually rising significantly. That's an indication that the virus is actually resulting in people getting so sick that they need to be hospitalized for a respiratory viral illness in the middle of the summer. That's quite an astonishing statement to make, but that's our reality.
Right, and Ziyad, when you look at this this variant, do you know where it first emerged?
It's really hard to track precisely because we're not really sort of testing and tracking things in the way we used to about 2 years ago. But it's very, very clearly it's actually now the predominant variant, or the variant sort of like dominating and overtaking all other subvariants in the US and much of the world.
Right, and Peter, talking about the directives that have come from the CDC. I mean, the CDC now says that anyone testing positive no longer has to isolate themselves for 5 days. Now the isolation period is going to be determined by how that person feels with the virus. I mean, what do you think? I mean, should people isolate for longer? And we talked about masks earlier on. Should that be reintroduced?
Well, it all depends on the context and who you are. I think that the masking has kind of been lost in the isolation guidance. So sure, we know we can go out in the world 24 hours after a positive test if you're feeling better and you have no fevers. But it's really vague about the masking part. So what I tell people, and if you look at some states like California, they're a little bit more explicit about masking. So you mask for at least 5 days going out and about. And if you live with people who are immune compromised or older, and particularly if they haven't gotten a vaccine in the last year, which is most Americans, older than 65, you probably want to be a little bit more careful at home because they're in your environments, they can get seriously ill.
Right, Kate, you were talking about the vaccines that are expected to be coming out, the new vaccines, that is, one at the end of the month, one in September, from the pharmaceutical companies. In these instances, would you recommend that everybody get it, or would it be just for people who already have sort of underlying health issues, people who are more vulnerable?
The CDC recommends that everybody get it. So we think that they should. Now, we know that more likely the people who are vulnerable are going to get it. And we urge, primary care health workers to really talk to more vulnerable people about getting the vaccine. But we do want everybody to get the COVID vaccine. But also be aware now that we have an RSV vaccine, and that's relatively new, and that's for people who are 65 and older, or for pregnant women, because it protects their newborn when they're born. So that RSV vaccine is a new tool in our toolbox that we have during the respiratory season.
Right, and one other thing, Kate, is that just in a couple of months, probably 3 months, 2 to 3 months, we'll be talking about the flu vaccine. Is there any likelihood that we could have a combination flu/COVID vaccine?
Yes, so Moderna is in the last stages of testing theirs, and it's been proven to be more effective than the combined vaccination alone. It won't be ready for this season, but it should be ready for the 2025-2026 season. And so that's really exciting because a lot of people are needle phobic. So having one needle rather than two will make a big difference to them. And also the fact that it's more effective is very exciting.
Mohammed, the WHO declared an end to the COVID-19 pandemic as an international health threat in May of 2023. Since then, though, only 35 of 234 countries continue to provide the WHO with information, with data on what is happening right now. And of course, we know that in these instances, information and data is key. What is the impact of this lack of information?
It has a very high implication. As Ziyad was mentioning, actually, we don't really know where from the KP 0.3.1.1 came from. And that is really the implication, that if we don't really have a continuous flow of the data, it's very difficult to trace down what is out there in the field. And if any of that variant would be way more pathogenic compared to the previous one, we wouldn't know until we have either the wastewater surveillance or we have a hospital admission. These are the only two markers for identifying the overall severity and the prevalence of the disease. And now, majority of the information WHO collects is through Sentinel-based surveillance system, which means it's only targeted few hospital identified localities where the information come from. So until we don't really have a population level or the country level surveillance data, assessing the disease and the projecting and the trajectory would be very difficult, and as is the evidence from current situations.
Right. Now, Ziyad, you've played a key role in the research into the effects of long COVID. These are people who've had COVID and then they've suffered from things like fatigue, brain fog, difficulty in breathing, etc. What have we learned about long COVID? Is enough time passed for us to know a lot more about why it's happening and how it should be treated?
Sure. So we know long COVID is caused by COVID-19. If there is, without COVID-19, long COVID would not exist on Earth. We know long COVID can affect nearly every organ system. So as you mentioned, long COVID can result in brain fog or fatigue. But it's not only that. It can actually affect the heart, the lungs. It can affect the brain, the kidneys, the endocrine system, the gastrointestinal system. It can affect nearly every organ system. And it also can affect people across the lifespan. We have kids, literally few years, like for kids with long COVID. We have people who are 101 years old with long COVID. So affect people across the lifespan, affect, men, women, affect people across race and ethnicity. So we know that vaccines, on the positive side, we know that vaccines reduce the risk of long COVID, but reinfection, repeated challenge with the virus actually raises the possibility or the likelihood of long COVID. We've actually made quite a bit of progress in understanding the mechanisms of long COVID. Why does it really happen? And I think I'm hopeful that we will continue to move the ball forward and progress our understanding. So hopefully we can develop treatments that work for long COVID.
Kate, in July, President Biden actually tested positive for COVID. That's while he was campaigning. Now, Biden, as we are aware, is 81. He was given this medication called Paxlovid, which can prevent serious illness and even death. But Paxlovid has also been associated with a rebound of the infections. So just how effective is it, and how great is the risk that you could get the infection again?
Paxlovid has been tested both in people who have been vaccinated and people who haven't been vaccinated. People who have been vaccinated, like President Biden, it protects about 51% reduction in hospitalization and death. And people who haven't been vaccinated or have not had COVID, that difference is about 89%. So it's highly effective. So for older people like Biden, or for people with chronic disease, Paxlovid really makes sense because it saves lives. And for the rebound effect, you can just have them isolate a little bit longer, wear a mask a little bit longer. So it's really not, to me, a concern that high-risk people should definitely get Paxlovid. And we currently have enough supplies so that everyone who needs it can get it. However, a healthy young person with no risk factors, it doesn't make sense for them to have it.
Mm-hmm. Peter, we were talking a moment ago about long COVID. What are you seeing in the United States, especially in a state like California?
So what we're seeing is that long COVID is going to be the legacy of COVID. There's still millions of people suffering with one or more of these 100 to 200 different symptoms. And I think that what we're hopefully seeing is the decline over time from Alpha to Delta to Omicron variants in the propensity. But like Ziyad said, every time you catch COVID or you get infected, you're kind of playing with COVID roulette, so you can't have chronic symptoms. We know that Paxlovid probably doesn't help with long COVID based on a randomized controlled trial at Stanford. So we're still searching for that magic bullet. We understand that some of it might be due to persistent virus that can be there longer than 16 months in some people. Some of it might be due to overexuberant immune system. And what we're probably dealing with is a whole host of diseases rather than one disease, hence the difficulty in finding good therapeutic options.
Right, and Peter, if we go back and look at the initial outbreak of the pandemic, more than 1 million people died from COVID in the United States. This was one of the highest rates in the world. Is the United States prepared for another pandemic?
Well, I think everybody's looking at H5N1 as a case example of whether or not we can take the lessons of COVID and put it to a new threat. And again, we're kind of falling short a little bit by not having enough muscle to do adequate surveillance of dairy workers. But we do have a test, drugs, and we do have a vaccine candidate. So the devil is always in the details. It's hardly easy to put money into prevention, but I hope we can learn lessons from COVID moving forward.
Right, and Mohammed, talking about being prepared, we're talking about that report that was issued in the United Kingdom, which was very critical of the manner in which the UK authorities had prepared for COVID-19. In fact, they'd prepared for another pandemic, a flu pandemic. Now, what happens in the UK for them to fix that? Do they retool their entire approach to how to deal with this?
Well, there is enough to learn through COVID-19 for any nations to really reflect on and do something so that we don't really suffer as much as we suffer with COVID-19. But I would doubt actually even the British government and the overall organizations for disease control, they are prepared for that. And then that is really witnessed even when, for example, influenza, as Peter was mentioning before, when it was one of the problems here in the wild animals, there hasn't been enough surveillance to really tackle that. So I would really doubt, put long story short, is that there isn't enough motivation and preparedness that can tackle a pandemic at the level we should have actually been doing.
Right, Kate, of course, the COVID pandemic had all kinds of effects here in the United States and around the world. We saw how people changed their work schedules, for one. And it also resulted in many healthcare workers leaving their jobs or cutting back on their hours. We've also heard of healthcare workers suffering from burnout, from the mental stress of having to deal with a pandemic like this because it happens so quickly. Have U.S. hospitals recovered, and are there enough healthcare workers right now to deal with another pandemic should it arise?
No, globally, hospitals have not recovered, and globally, we are not producing enough health workers to fill the gap. To take a look at the U.S., nurse vacancy rates are hovering a little less than 10%, and over the next few years, the U.S. will add about 200,000 nursing jobs a year while only training about 178,000. So this challenge will increase and continue. And in fact, this year, the Biden administration instituted ratios in nursing homes, nurse to patient ratios, and that, which although a good move, will exacerbate the shortage. So we need, both in the US and globally, a full-scale program to scale up nursing schools and get more people trained and more people ready to work.
Right, Ziyad, very quickly, can you tell me in 20 seconds, what happens with the development of vaccines? Is this research continuing?
Oh yeah, as mentioned on the call, now there is an effort to actually develop or validate and test a dual vaccine for COVID and influenza.
Right.
That's really will solve some of the vaccine uptake. There's also quite a bit of development on mucosal vaccines, those
Right.
vaccines that actually may block infection, so that's really also important. And new so there's a lot in this area that we're hopeful that.
Right, thank you. We are going to have to leave it there. We've run out of time. Thank you to all of you for being with us. That's it for this edition of The Heat. I'm Anand Naidu in Washington, D.C.
The nature of business is to bring value. Business activities in